for this unique CMU on rheumatology. And we are very fortunate to have Dr. Vijay Vishwanathan as a speaker and Dr. Abasaheb Patankar as a moderator. So you can expect that you are going to have a feast because these two personalities, because we know Vijay, he is one of the best in rheumatology right now in Mumbai. And Abasaheb Patankar knows how to take the most information from the speaker. So please enjoy this CME. And I now request our dear President, Dr. Gawalkar sir, to give his presidential address.
Thank you, Vikas. Good evening to all. Respected our today's guest speaker, Dr. Vijay Vishwanathan sir, my IIP President, Dr. Gangulia sir, Dr. Dabadkar sir, past Vice President and Godfather of IIP Raigad, Dr. Jitendra Gawhane sir, President, Navi Mumbai, and all the dignitaries, and today's moderator, Abasaheb Patankar sir. Good evening to all. Dear friends, whenever we come across a fever of long duration, we need to think something more than what we are practicing in our office practice. Fever is not fever of prolonged duration is not a antibiotic deficiency stage. We need to think something more, something non-infectious causes like malignancy, like rheumatic fever, like combined immunodeficiency, various causes. Because as the duration of fever increases, the possibility of infectious cause goes down. So just to update our knowledge in rheumatic fever, rheumatoid arthritis, we have planned this lecture and we have got an expert, none other than Dr. Vijay Vishwanathan, the only rheumatologist in Navi Mumbai and for Raigad people. So I request Dr. Dr. Abasaheb Patankar to take over the charge and proceed further. Thank you. Thank you very much.
Yeah. Thank you, Pramod. Thank you, IIP Raigad, for this opportunity. I welcome you all for this rheumatology CME. I'm quite delighted to see almost around more than 38, 39 people have joined at this 9:30 p.m. session. It is all charisma of Dr. Vijay, nothing else. So Vijay, you are here for us and you are always there for us. So what, as a generalist, I want to know? As a generalist, I should know when I should suspect a rheumatological disease patient, especially when he comes with a joint pain. If at all, at least some disorder which I should not grossly miss it. Is it possible to diagnose few of the diseases in rheumatology in office practice, especially when a busy schedule is going on presently and otherwise also? Is it possible to do some basic lab test, which of course, not as a panel, but if you suspect something, then can you go ahead with some few basic lab tests? And if at all, are there any diseases where a general pediatrician can start some treatment, maybe a basic, maybe NSAID or basic some treatment? If at all, if he wants to start, definitely it is only possible if you have got good clinical history taking perspective as well as good clinical examination, especially if you are examining a joint and gait, because that is the basic by which you start with it. As we know, rheumatology is a very vast subject, but we know Vijay always makes it so simple, and his few of the slides are so well known that the moment you come to some across, if the ESR is raised and CRP is raised, we have 3 digits and all, we come to know that is something grossly which is happening in the patient, and we start suspecting rheumatological disease, as well as we start looking for Vijay, whether he is around or not. So Vijay is a very good friend of mine. We are know each other since more than 28 years. Apart from this, he has done fellowship in pediatric rheumatology in University of Western Australia. He has got 17 publications in Index Journal. He has got 25 poster presentations in 9 international, 6 national conferences. He has got 8 chapters written in textbooks and he has got more than 60 presentations. I'm quite delighted to see that there are many stalwarts are present for this. Dr. Dabadkar sir, Dr. Jitendra Gawane, Dr. Hemant Gangolia, Dr. Sunita Engre madam, Dr. Daruwala sir, Dr. Chitra Kulkarni madam, Dr. Anjali Muthu, Dr. Anjali Gokarna, and even Madam Vishwanathan also, she is also there. So few of the names I may be missing, but I don't want to waste much of a time. I'll straightway hand over to Vijay for further proceedings and further presentation. Thank you.
Thank you very much, Dr. Abba Sahib. You are always been a dear friend and a great colleague to have. Dr. Wankede sir, for giving me this opportunity to share whatever I have seen over the last 12 to 15 years in my day-to-day practice. And all these cases is going to be a case-based story like usual. And all of them have been referred by a pediatrician from where I practice. So, am I audible? Hello?
Yeah.
Yes, sir.
Perfect.
Yes,
Perfect.
Yes, you're audible.
perfect.
Perfect. So, please feel free to stop me anytime because I thought it's probably one of those situations where we don't get access to a pediatric rheumatology story. So, I have got around 60 slides, which is better than 215 that I had the last time around. So let's go slowly and steadily, and please feel free to stop me whenever you feel like. So the theme that I thought that most of us as pediatricians have always been taught to stop to actually start looking at the patient. And I'll just start with this kid. These are two live patients that actually ended up in my OPD or my busy office practice. And this was the other one. One was a self-referral and the other was referred by an endocrinologist. So obviously, if I ask you the question, do they look sick? Answer is probably yes. But then what happens to these two kids will be wiser by the end of the lecture. So the first message that I want to send home is, even in a busy office practice, you need to think of rheumatology to diagnose rheumatology. And the second patient did not help me by wearing a t-shirt. Now the kid on the right side actually came with a reference of endocrinologist saying it's probably a juvenile rheumatoid arthritis, and very uniquely the t-shirt flashed JRA. I've never seen such a t-shirt in my life. But then it looked like a JRA, but when you actually start seeing, it turns out to be something else. So take home message from this slide, stop looking, start seeing. Even in a busy office practice, if not rheumatology, think of the poor rheumatologist who's waiting for your referrals. So dista tasa nasto. So let me start with two simple cases, which every year I see about 4 or 5 of them. So most of the pediatricians in Raigad and Navi Mumbai and Thane are educated enough and aware enough to the fact that when I see a 14-year-old girl with polyarthralgia, symmetrical large and small joint disease, and the pediatrician is smart enough, Vijay ने बोला था 14 साल की लड़की है, 14 joint है तो RF भेजना. And sure enough, the rheumatoid factor comes positive. And most of us will never forget to write ESR, at least in this part of the country. So the ESR comes back as 40. Otherwise, the CBC is reasonably unremarkable. And the pediatrician says, Vijay ko milne tak naproxen shuru kar dete hain. And then the child gets started on naproxen with RF positive disease in a 14-year-old, looks very, very classical. And then the child decides to get better on naproxen and stops the naproxen. And then the pain recurs. But very uniquely, when you start seeing the child, there is hardly any swelling. There's only arthralgias. And then you repeat a rheumatoid factor from a standard laboratory, it comes negative. And then you do the usual test, which all the pediatricians are extremely clever at. Vitamin D level comes sky bottom or rock bottom, I should say, sorry. The vitamin D gets started and this child gets better. So this is a perfect situation where a deficiency of vitamin D can manifest as polyarthralgias, because of lack of calcium. And this is a very common scenario which most of us are well versed with. So vitamin D deficiency mimicking arthritis. What happens to this other girl? In fact, this girl came on the same day. In the morning, I saw the deficiency kid, and in the afternoon, this child is a 12-year-old female. Being a Vishwanathan helps because this girl also happened to be a Ramakrishnan or a South Indian, very well trained in dancing. And suddenly she's an adolescent girl, starts to complain of a lot of pain and increased fatigability since 3 to 4 months. So the referral was obviously whether it's an evolving SLE-like disorder, etc. And sure enough, based on the previous case, this child was obviously went to the orthopedician. Vitamin D was checked, it was 19, and then the ortho advised 6 packs of 60,000 vitamin D, and then there was some improvement. But this super anxious South Indian family went to another pediatrician who was very busy, who did not know the history, and he also prescribed vitamin D because the same problem is consistent in most of the OPD scenario. But then what was missing was this child, when she came to me, there was an additional history of abdominal pain and constipation since all these things were happening. And why should a 12-year-old be constipated, right? And then you took a detailed history, and turns out that the orthopedician had given 5 doses of vitamin D, 60,000 units, and then the medical shop had given them 10 sachets, and then the parents were not convinced, and the pediatricians added a few more sachets, and then the total cumulative vitamin D dose was almost to the tune of 1.2 million units or 12 lakh units. And I just did the vitamin D level and it came sky high. So this is not an unusual scenario where an overzealous treatment with vitamin D in a busy OPD, just ignoring the past history or what is even the last 2 weeks ka history. And remember the age-old mnemonic, stones, bones, groans, and psychic moans as pointers towards hypervitaminosis D. In fact, stopped the vitamin D and put this child on naproxen, almost started steroids to get out the calcium out of her bone, but she recovered completely. So these are simple examples that can come in the OPD. Take home message is the previous kid and this kid, both of them had severe arthralgias, but never had any evidence of florid arthritis. I'll show you some pictures in the next few slides. Remember, a chronic inflammatory arthritis is a process which starts in the synovium. So you almost always will have a joint swelling. It's not just restricted to a arthralgia alone. It has to fulfill the triad of pain, swelling, and restriction of movements. And remember, as much as I am a big propagator of an ESR, a high ESR does not usually mean inflammation. It could be non-specific at times. I will take back my words in the next 15 minutes. So this was another example where and this case was referred to me by a very senior pediatrician saying, Vijay, मला हे बाळ 5 वर्षाचा आहे, 1 वर्षाचा असताना पासून त्याला हे ताप येतोय आणि हे सांधे असे दिसतात. I think this is something like an auto-inflammatory disorder, which was probably half the battle won for me because the pediatrician, despite a busy 100, 150 OPD, at least thought that this could be an auto-inflammatory disorder purely based on history, that this child had fever starting early infancy. So 6, 7 months of age. Now the child is 5 years. Every single day, this child is running fever. And you can see that this child has super symmetrical and boggy synovitis. And the child gets referred to me. So what do I see is something very unusual. So this is the same child. Besides the joint, I start seeing a rash. And this is, in a dermatology OPD, would have been an ichthyosis or an ichthyosiform rash. And then I start doing what I do normally. When I think of auto-inflammatory, I just flash a torch in the eye, pretending to be an ophthalmologist. And sometimes you do get lucky because even to the torch and your naked eye, you can appreciate that this pupil is a festooned pupil, or it's an irregularly pulled pupil suggestive of a chronic uveitis. And this child never had any complaint, which is obviously because of the binocular vision. And I sent this child from my OPD to the ophthalmologist. So the pediatrician looked, I saw the child, and the ophthalmologist put his slit lamp, and then he just shouted, saying, Vijay, this boy has got chronic uveitis, and the description is very typically what is called as mutton fat keratic precipitates. And lo behold, when I start seeing rash, arthritis, mutton fat KPs, my diagnosis is straightforward. This is sarcoidosis. And the ichthyosiform rash and the early onset in infancy proves the diagnosis of Blau syndrome, which has a genetic component to it. I got the synovium biopsied, which was laden with granulomas, and the exome sequencing clinched the diagnosis. So it all starts at the pediatric office, and what the patient comes and shows, the pediatrician has to be just spend that extra time when you see such kind of cases, and timely referral clinch the diagnosis. So I won't touch about auto-inflammatory syndromes henceforth in the current presentation, but remember, take-home message, a child with high-grade fevers starting in infancy, once you start ruling out sepsis, etc., start thinking that it could be either a primary immunodeficiency with inflammatory conditions or pure auto-inflammatory conditions. These are two kids. One is a 13-year-old boy whose weight is 75 kgs. And he has pain in the left knee joint, hip joint, groins since 1 month. And now the clever pediatrician knows, Vijay ne bola 13-year-old boy, lower extremity, pakka B27. So remember the rule, below the belt, B for a boy, B for B27. And this history was even more supportive because the father had ankylosing spondylitis, and this child's also tested positive. And then the diagnosis was offered at the pediatric level as enthesitis related arthritis. And the child was started treatment with sulfasalazine and naproxen. Instead of getting better, this child's pain actually started increasing in the next 3 months. And then this child was referred to me. And when I saw this child, one simple history that this child, does he have a morning stiffness or does the pain worsen in the evening? The history was शाम के टाइम पे ही दर्द ज्यादा होता है, and especially in the late evening hours. And when you look at the thighs, you can see that there is significant wasting of the thigh muscles. And this is a situation where I use X-rays extremely rarely, but then the history didn't fit. A naproxen should take care of the worst of arthritic pains. This is a boy who was on a disease-modifying drug as well as an NSAID and still wasn't getting better. And the clue remained that this was a 75 kg. So this is an overweight adolescent boy with a second half of the day pain. And sure enough, the X-ray came back showing slipped upper femoral or slipped capital femoral epiphysis at used to be called as. And again, the B27 was a red herring, right? So the history is extremely crucial. Remember, very few cases of juvenile arthritis starts from the hip joint. Even an enthesitis related or a B27 seldom starts from the hip. It usually starts from the periphery. There is no type of arthritis other than the odd ones who will start with the hip joint. Take this 5-year-old male, again limping for 2 weeks, and the pain is very vague and pain is over the knee joint. But there is hardly any swelling that can be appreciated. And on the examination, the hips are restricted in internal rotation. And the child, because it's a 5-year-old in a busy pediatric OPD limping, gets diagnosed as a transient synovitis, which is a decent thought. But then the transient synovitis of the hip should respond to 2 to 3 days of naproxen. This boy's pain, like the previous boy, kept on worsening over the next 6 weeks. And then again, I do the X-ray because transient synovitis of the hip very, very rarely can manifest or complicate into a avascular necrosis of the hip. This boy actually turned out to be Perthes disease, where the whole head of the femur is destroyed. So again, the clue is simple. you don't get vague increasing pain in a transient synovitis. It is an extremely painful condition. You don't have it lingering on for 4 to 6 weeks. It's just a simple history which cleans the diagnosis. So what are the take home messages? In the first case, inflammatory arthritis always ask for morning stiffness. The mechanical pains or the leukemic pains are the ones which start in the second half of the day. The mechanical pain worsens with activity, whereas the inflammatory pain gets better with activity. The hip joint, again, remember the age old rule that the hip pain can be referred to the knee, and which explains why the knee was being complained, whereas the problem was coming from the hips. HLA-B27 is positive in 8% of normal people without having the disease. So do not send the test unless there is a solid reason. If it comes positive, try to correlate it with the clinical picture. And as far as the other kid was concerned, remember that a slow progressive hip issue, often think of Perthes disease, and early stages AVNs can be normal as far as X-rays are concerned. JIA does not begin from the hip joint. Only select exception is enthesitis. Very, very, very rarely you may have a systemic arthritis as a part of JIA. So most of us who do not have read rheumatology during our PG days, which is probably the case till last maybe 10 years back, all these joints will look the same. So what we are going to learn from here onwards is a good history and a clinical examination will often help you notice the subtle nuances and try to dissect out the cases. So when do I suspect rheumatology, or when do I ask my colleagues to suspect rheumatology? The answer is always. My job becomes extremely easy in an OPD because I only have 10 seemingly uncommon diseases to rule out. The pediatrician's trouble is he has to think of 1,000 infections, 100 malignancies. So rheumatology ka number aata hi nahi hai. I have 10 rare diseases which I don't diagnose. I just rule it out. In the process of ruling out, I end up diagnosing. But to cut the story short, these are commonly 4 situations where you may want to think of possible rheumatological cause. So some basic rules, I'm just summarizing. So next time you see a joint, so the next few slides are a child who presents with a joint swelling in your OPD. It's always good to make a sentence comprising of the age of the child, the gender of the child, is the child sick or not sick? Is the swelling acute or subacute or chronic? Are the joints large or small or both? Is it upper extremity, lower extremity, or the spine or axial skeleton? Is there morning stiffness or the pains are more in the night time? The most of uneducated patient will give you a history of morning stiffness. Is the pain additive or fleeting? Additive, we know that could be a reactive or an inflammatory process. The fleeting joint we know is acute rheumatic fever. One more reason for a joint pain that fleets, think of a possible malignancy or a leukemia. Is there more of swelling or more of pain? Relative context. More of pain probably means reactive osteomyelitis, leukemias, reactive arthritis, and more of swelling often tells you that the problem is in the synovium. So it's more likely to be an inflammatory arthritis. And last but not the least, see if there are any systemic symptoms. So we've discussed this. So morning stiffness is almost always inflammatory. सकाळी उठला उठला त्रास होतो, अर्धा 1 तास चालतच नाही, वर्सेस रात्री झोपच उडते त्या बाळाची, झोपायलाच जमत नाही. That is a sinister sign, could be malignancy. The happy child the next day morning is a growing pains, whereas the sick child with low grade fevers etc. rule out a malignancy. Very typically, the lower extremity joints often end up being a reactive arthritis, what used to be called as Reiter's syndrome. Acute rheumatic fever typically hits the lower extremities. Enthesitis related arthritis, we know that the B27 is often the lower extremities. When you start having the upper extremities and the lower extremity, then the list increases to either a post-infectious reactive a systemic process, or a systemic arthritis, or other collagen vascular disorders. And when you have exclusive upper extremity arthritis to begin with, in an adolescent girl, think of rheumatoid factor positive polyarthritis. If you have a spine, remember, as a rule, the spine is seldom affected in the juvenile idiopathic arthritis at the onset. And even most of the kids who end up having a lower lumbar vertebral lesion end up becoming an adult before they start having these issues. So when a child presents to you in a busy OPD with back pain, please think of a leukemic process or a malignancy. Infectious process, definitely tuberculosis, etc., needs to be ruled out. Infective discitis has been described. And then you probably would scratch your head whether it's probably a B27, inflammatory bowel disease, etc., can have low back aches. Additive versus migratory, I have talked in the previous slide. Most important is, in a busy OPD, think, is there more of pain? Is there more of swelling? If there is only pain but hardly any swelling, and it's a short history, you may give a trial of naproxen. How does it help? I'll show you in the next few slides. If there is predominant joint swelling, like the child who I showed you with the boggy synovitis, think that there is probably an inflammatory process, and this is a child who needs a more detailed rheumatological thinking. So let's run through some basic common situations where you don't need to wait for fulfilling the 6 weeks definition to diagnose rheumatology. So this is a very typical scenario, a 2-year-old girl who's limping for 2 weeks, and the pain and limp is worse in the morning for 2 hours. So, and the child gets better by afternoon. And very typically the parents are not very sure, but they think that the ankle, sometimes it's the knee. And the clue is there is more of swelling and less of pain. And this is a child who will be happily limping. And you just have to see a subtle drag that this child has. There's a right ankle arthralgia. And when you examine closely, this is a very typical, when the age is 2, number of joints are 2, morning stiffness, acute phase markers. When you do, the ESR is low. And the straightforward diagnosis is when you start looking at a 2-year-old girl with a 2 joint with an ESR of 2 or 20, always diagnose juvenile oligoarthritis. And this is a child where a subtle clue in the form of a high platelet count. So remember, when you see a slightly higher platelet count and the child is not significantly anemic, then you will often think it is an inflammatory process. And the only one test that I may want the pediatrician to do is an ANA by immunofluorescence, no ELISAs, and a positive titer that most of us will be looking at is 1 in 160. And ANA in this setting becomes important because a very high ANA pushes this child at a high risk for iridocyclitis. Simple. So this is the same kid. Why is it important to diagnose JIA or an oligo JIA soon? Is it's not life threatening, but if this chronicity goes on for some time, you will end up with a limb threatening disease. So limb length discrepancies are often a problem with JIA, and a simple 120 rupee injection inside the knee joint will fix up this joint within 48 hours, right? So juvenile oligoarthritis is the classical situation. So now tomorrow morning, one of the audience is going to see one of these kids. So these are 2 kids who came back to back. Both, one was a female, one was a male. A 3-year-old female with a left knee for 4 weeks and a 3-year-old male with a left knee for 4 weeks. And now we are all wiser. We will ask morning stiffness. Both of them had morning stiffness. The kid on the right had low-grade fevers, but not documented, right? And then the kid on the left had platelets of 5.6. And now we know that when I see 5.6 platelets, I will look if he's anemic. Not anemic, then it is inflammation. ESR is 30. And Vijay has said, when everything is low, 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 age is low, joints are low, platelets are high, ESR is low, send an ANA. And ANA comes as 1 in 320. What happens to the kid on the right? Exactly similar CBCs. Again, morning stiffness means there is an inflammatory process. 4 weeks often rules out a septic arthritis. Platelets are inflamed, but then ESR is 80. and then still we send an ANA because age, joints, everything fits like oligo GIA. ANA comes back 1 in 100. So what are we looking at? So the take home message is, when I start seeing an ESR which is very high in a single joint, 2 week history, think of septic arthritis, osteomyelitis. 4 week history, please start thinking whether it is tuberculosis in our country. This kid was from Panvel, so obviously we got a Mantu done, and then the Mantu came strongly positive. And this was the smart pediatrician who picked it up and referred it to me. काहीतरी गडबड वाटतोय मला, ESR 80 नाही पाहिजे या बाळामध्ये. And that's the take home message. When you look at a high ESR in a single joint, please do not see JIA, or at least rule out a tuberculosis. And lo behold, do a biopsy and it showed caseating granulomas. So a single joint, normal ESR, JIA, single joint, high ESR, rule out alternative causes. If not infection, chronic infection or malignancy. So what happens when you have, instead of a 2-year-old, a 12-year-old girl? So I saw this girl and boy. So the left was a 10-year-old girl with large and small joint swelling with morning stiffness, and diagnosis was suspected JIA. Whereas the kid in the right side was referred with same large and small joint swelling, extremely symmetrical, suspected JIA, but hardly any stiffness. On further history, the kid on the left was symptomatic only since 5 weeks, whereas the kid on the right was asymptomatic since birth. And from age 4, even without stiffness, the child started having contractures or arthropathies. I'll show you the picture in the next slide. Sorry. The kid on the left was restricted with terminal movements, whereas this kid on the right was having extreme enlargement of the interphalangeal joints, and this child had actually become deformed even without any history of stiffness. And the kid on the left was rheumatoid factor positive with a high ESR, whereas the kid on the right was expectedly ESR was very, very normal, and the tests were negative. So this is how the child looked like. The kid on the left with morning stiffness, with the adolescent age group, with severe wasting, huge swollen joints, chronic arthritis. This is proper juvenile idiopathic arthritis. And you can see, as much as I say that polyarticular JI is often symmetrical, I'll show the other child. This was the other boy. This is not as symmetrical, whereas this is extremely symmetrical. And this had inflammation followed by stiffness followed by deformity. This boy started deforming even without stiffness. And the first thing that you look is he came across as a 10-year-old, but his height was extremely short. And you do your basic anthropometry, which is very easy in the OPD also. I thought that this boy has a short trunk dwarfism and not a short limb dwarfism. And I got his skeletal survey done. You can see that the epiphysis, etc., is extremely enlarged. And this is the X-ray. The kid on the left side with bad disease or inflammatory disease has got a crumpled carpal appearance, almost osteopenic, and then she's ended up with a fixed deformity. And the other wrist, I injected Kenacort, which is an intra-articular steroid, and you can see the difference that early diagnosis or early referrals make. This joint was just starting, and this had already fixed. Whereas this other kid, who I thought was a short limb dwarfism, a short trunk dwarfism, has what is called as platyspondyly. And you can see the epiphyseal edges are all swollen. And this was a very typical spondyloepiphyseal dysplasia. What was the clue? There was consanguinity, there was a short stature, hardly any stiffness, acute phase markers normal. So the child was actually showing you everything that wanted to be seen. And then obviously the acute phase markers were all normal. And then this confirmed the diagnosis of a skeletal dysplasia. So again, two scenarios where you have symmetrical arthritis and symmetrical arthropathy. So start using the right words. Arthritis is inflammation. Arthropathy is contractures without inflammation. And the diagnosis becomes easy, right? This is a scenario which I am pretty sure I see a lot. I've been seeing a lot in the last few years, which I think I should not be seeing so many. But let's go through this story also. This is a 5-year-old girl with low grade fever, not documented, and right elbow and feet pain, referred as juvenile oligoarthritis. Now, all of us know 5-year-old girl will probably end up having JI, oligo JI. But when you examine this child, you start seeing that this child has what is called as periarticular. I'll show you a picture, right? But then, very peculiarly, I have to show this slide again and again because this child in 2 weeks had 4 CBCs and only 1 ESR and 1 CRP when there was no ESR. The counts were seemingly normal. However, the differential counts were lymphocyte predominant, 60, 55, 62, 60. And if you think like a rheumatologist, any platelets which is hovering around the 2 lakh mark in a setting going on for more than 2 weeks, think that the platelets are slightly on the lower side. Sure enough, it did go below 2 lakhs also. And the only time the ESR was done, it came back as 110. And again, the anemia of 9.5 does not explain a low platelet. ESR 110 is a bit of a problem for me. And then, but then to be fair on the pediatrician, he started this child on naproxen and said, "फरक नाही पडला तर जाऊन विजयला दाखवून घ्या." And then this is the picture that I want all of you to take home. The kid on the left, this swelling is pretty much like the Blau syndrome swelling I showed you. This is called as articular swelling, or you can see that the synovium is inflamed. The kid on the right side has got what is periarticular. So the whole feet seems puffy or swollen. And this child was having a very typical history that this child could not walk. However, she was able to swim and cycle. How does that make you wiser? Obviously, the child who has pain on weight bearing tells you that it's more of a bony process and less of a joint process. A child with an articular swelling will probably be limping more. So when you start looking at an articular swelling, you see an inflammatory process. And when you start looking at a periarticular swelling, you obviously rule out malignancy, or you think of a malignancy. And sure enough, this father calls back and says, ताप पण येतोय आणि औषधाने काहीच फरक पडला नाही. And there is an additional involvement of the left ankle. काही पण करा, ते 10 रुपयाचं औषध जे तुम्ही बोलले ते देऊन टाकू का? This child does not sleep at nights. He is extremely miserable. I said, udya sakali fasting sample, repeat these tests and come and see me. And then this child comes back with again a count which is 13,000, but lymphocytes are going up, platelets are dropped, ESR is 3 digits, LDH uric acid, LDH is high, uric acid is normal. So take home messages. I said, let the hematologist rule out the leukemia for me. Then I will start scratching my head. And this girl ended up having a acute lymphoblastic leukemia. Take home message. Please do not say smear normal ahe, leukemia nahi. Leukemics, 50 to 60% of leukemias in the pediatric age group starts with musculoskeletal pain, by which I mean nocturnal pains. And the golden rule, send an ESR, platelets and ESR going in opposite direction in a child with low grade fevers. Even if it is not a malignancy, please do a bone marrow before giving steroids. Do not go on absolute normal CBC, because the disease starts in the bone marrow and then spills out in the peripheral circulation. So by the time you start seeing blasts, you may have missed the boat. The key is to pick up leukemics when the disease is localized in the bone marrow. This was a kid who was referred to by my pediatric orthopedician, right? अरे विजय तेरे टाइप का कुछ तो है, पक्का arthritis नहीं है. While I was leaving Jupiter, And this boy was an 8-year-old boy, polyarthralgias. Again, mark the words, arthralgias. Hardly any swelling. The adult orthopedician had called it reactive arthritis. Very interestingly, the adult ortho had done an ESR which was 120, and the child was given steroids. And despite the steroids, this child was in severe pain. And he went to a pediatric ortho who referred the child to me. And then when I looked at this child, there was some periorbital swelling, a little bit of mucositis. And I obviously thought, is it lupus or something else? Let's open the mouth and see. And this child actually had a gingival hyperplasia. The last time I had seen gingival hyperplasia was in Harshmohan's textbook of pathology. But then it seemed to fit in because this child was again gingival hyperplasia, a 3-digit ESR, a sick child who was having pain despite steroids. Please do a bone marrow, and this turned out to be an acute myeloid leukemia. Rare but not unusual, and do not be in a rush to give steroids. The worst of reactive arthritis will respond to naproxen, at least, right? So this boy, again, the kid who I showed you, was extremely sick, and this boy was having hardly any swelling, comfortably sitting in the parents' laps. But the minute you start asking him to walk, so this is how he can hardly put his feet on the ground. And again, there is significant amount of pain. This child looks sicker and sicker, and then this child, and this was just a 1-month history referred by a pediatric endocrinologist because someone had done parathyroid hormone which had come low. And then this kid, the last kid, I'll show you this video also. So what am I trying to demonstrate here is nothing but a severe bone pain or a shin pain, sick child. This girl was given steroids for 6 months and turned out to be having a leukemia. This boy was also referred to the hematologist, and I said, please rule out the leukemia for me because there is hardly any swelling for the amount of pain that both these kids have. And all of them had a normal CBC and a very, very low grade grumbling ESR, etc., because steroids had messed up the whole story. And this was the kid who actually almost foxed everyone into thinking that it's a JRA. So remember, there is nothing called JRA. There is only JIA. And please rule out a malignancy when things don't fit in, right? So no swelling and lot of pain. Very again, another 2 interesting kids. One presented with upper eyelid swelling and one presented with lower eyelid swelling for 2 months, and this was 1 month. Fever for 1 month, both of them low grades on the right side. The kid on the left had a wrist pain. The kid on the right had foot pain or ankle pain. Morning stiffness versus nocturnal pain. CBC is almost normal, except it was leukopenia, lymphopenia, pancytopenia, low platelets, and the kid on the right side had more of lymphocytes, and CRP negative ESR 80, CRP negative ESR 120. It's a very easy diagnosis to make because now we know that the kid on the left side, I actually looked into her mouth because I keep looking for SLEs always in girls. And this child had hard palate ulcers. And sure enough, I thought of an SLE in the kid on the left side. The kid on the right had nocturnal pain. Again, like the previous situation, hardly any swelling, but severe pain and tenderness. ESR in 3 digits. So rule out the leukemic process. But what gave the clue was again the joint. Remember, an articular could be JIA, could be SLE, could be systemic arthritis, sarcoidosis, etc. Whereas this swelling, where the child just doesn't put the feet down, but when you lift this child up, she's perfectly fine. That is a very, very classical leukemic pain, right? So take home message, articular, periarticular. A very common office scenario, especially in the Raigad belt, as I often see a lot of such kids from Panvel, Uran, Mandgaon. He's a 2-year-old or a 3-year-old up to 6, 7, 8-year-old boy or girl has fever for 10 days. So remember, you don't need to wait for 4 weeks to call it PUO, because by day 10 to 14, you would have ruled out most of the known infections, even the unknown infections probably. And all I wanted to ask is, what is the history of fever in the virgin state before parents start corrupting with mefenamic acid, etc. And sure enough, these are the kids who will give a classical history like morning stiffness, एकदा येतो की दोनदा येतो, पण fixed time ला येतो. The typical description is संध्याकाळच्या time ला एकदा येतो, but occasionally you will have fixed time around, or at least the fixed hour of fever, 1 or 2 per day. In between, the child is extremely happy and playful, and you start wondering what is the problem when this child दिवसाला 2 वेळेला शनी येतो, is what I used to explain the parents. ते 2 वेळा शनी येताना बाळ एकदम त्रास होऊन जातो, हात दुखते, पाय दुखते, the child is just miserable, and that points to a cytokine storm or a fixed time release of cytokines. And no prizes for guessing that this is a child. When you do a CBC, you will have anemia of chronic inflammation, white cells will be high, extreme neutrophilia, high platelet count, in ESR and CRP both going in one direction. One test only to be done, ferritin, maybe 500. If you miss this fever pattern, 500 will soon become 5,000. What is that? We'll see, right? So this is a very, very common office scenario. Continuous fever for 10 to 14 days, 1 or 2 spikes, otherwise absolutely normal in between. Think of tuberculosis and diagnose systemic arthritis. And most of us have seen the classical quotidian fever pattern. The rash that typically comes with the spike of fever may not be, the history may not come upfront, but if you look at the child, you may have urticaria or pink colored macular rashes, which often looks pretty on a fair skin, but in a dark colored skin, you may still start appreciating the rash. The places to see the rash is the cheeks, face, chest, back, etc. Right? And sometimes you may start seeing what is called as dermographism or dermatographism or Kobner's phenomenon, which is also a kind of a sensitive marker for a systemic arthritis like process. So from a 25,000 count, when it drops to 2,500, and the happy child with once a day fever now starts becoming sicker and sicker. Remember that this could be the presenting feature at your hospital also. A child who is very sick, you do the, with a history of fever for a week, a sensorium that's going down, liver and spleen palpable, pancytopenia, with again a neutrophilic predominance, a liver function test which is showing transaminitis, and a ferritin comes back as 44,000. But before ferritin, please remember that we will still continue doing the easier things, which is send an ESR and CRP. And what happens in this scenario, the CRP is extremely high, whereas the ESR is not that greatly high. The rule of thumb is ESRs and CRPs should either be normal in a happy child, or should both of them should be extremely high in a sick child. The minute you start seeing relative discrepancy, you start thinking this could be a macrophage activation syndrome. So what can a busy pediatrician do in his OPD when he is in his OPD and the sister keeps on saying "Tyala taap yetoy, taap yetoy, taap yetoy," right? Assuming that this child has been in the hospital for about 7 to 10 days, and parents are also spiking. So this is where the naproxen test comes handy. What used to be called as the aspirin test in the past, what we do nowadays is a naproxen test. So a child who has musculoskeletal symptoms and fever, give a 3-day naproxen challenge. If both of them respond, the diagnosis is it's an inflammatory process, Vijay ko phone lagao. If the fever responds, but the musculoskeletal pain persists, Vijay ko bula sakta hai, nahi to Vijay ko milo via Dr. Nitin Shah. So rule out a leukemia, because the bone pains will not respond to naproxen. Unfortunately, if neither of them get better, then you will have to really start thinking, am I missing out on some occult infection, tuberculosis? And the whole world is moving towards a PET-CT scan in the diagnostic algorithm for PUOs. This is a very important and a very easy thing to do whenever you are stuck with PUOs. This is the same child who comes to 3 pediatricians. For want of an example, let's assume the first scenario is in Ratnagiri, fever day 6, and a busy pediatrician does a CBC, HB is 10, white cells 25,000, platelets 7 lakhs. A very happy scenario for the rheumatologist also, because I know that this is an inflammatory process. The pediatrician will use the word probably infective process. The only take home message is start paraphrasing 25,000 counts as a probable inflammatory count more than infection, because we are not sure, right? So inflammatory counts, it could be infection induced. And but then this child doesn't get better with the usual antibiotics, etc. From Ratnagiri comes knocking at the Raigad doors. And then the pediatrician does a repeat CBC, because this is the same child who is not getting better. And this time the counts have dropped from 25 to 15,000. Platelets have come back as 1,90,000 on day 10 of fever. Again, a perfectly normal or a really not something earth-shatteringly problematic CBC. But remember, the child is not getting better and the fever spikes are increasing. So how much ever busy you may be in the OPD, please keep a watch for what has happened in the past. Sorry. Right. So you can, and then if you disregard this second CBC as normal, and then you, unfortunately, this child will end up in Panvel in the ICU with the last CBC. Now, can this have been averted? Answer is obviously yes. Throw in an ESR and CRP at every visit, you pen a CBC. For people interested, I have a magic pen which does not stop at CBC alone or a urine alone. It stops only when you finish CBC, ESR, CRP, SGPT, creatinine, and a urine. What happens in the trend? The first child is obviously is perfect to my satisfaction. Everything is high. Counts are high, platelets are high, ESR high, CRP high. Always think of rheumatology. The second situation, CRP still continues to be high, but the ESR has dropped. A 120 to a 40 means the child should be getting better. The child is looking sicker. So this is a problem for me. And then a 7 lakh platelets dropping down to 1.9 lakhs is a more than 50% drop. So let's try using Dr. Amdekar's examples. This is a normal looking platelet, but it's a low normal and it's a big jump or a big drop. And then if you miss that, then you will end up with a low fibrinogen, ESR 15, very high CRP, and cytopenia. This is frank macrophage activation. So the first condition, what is called as inflammatory phase, you may end up doing a marrow and find Kana Koprayamade macrophage activation, may not manifest clinically. The second situation is when the fever pattern changes from intermittent once a day happy fever to continuous child looking sicker and sicker, what I call as subclinical mass. And the last situation is not something that you want to be in. So remember, I can't have any presentation anywhere without this slide. Elections are still a couple of years from now. No political affiliations, but remember, you cannot separate ESR from CRP. This is a slide that all of you have probably seen umpteen number of times. But remember, a high ESR, high CRP infection, serositis, synovitis, a very high CRP and a low ESR in a sick child, please rule out macrophage activation. Negative CRP and a very high ESR is very typically SLE. And when both of them are normal, think that you are out of trouble. So beware a 3-digit ESR like we have seen. Beware a normal ESR in a sick child, and please start doing an ESR or please continue doing an ESR, as if I may say. One more example where the ESR comes handy. This is a 13-year-old girl who's been running fever for a year on and off. backaches and body aches and arthralgias, vague symptoms, but then significant enough to visit the pediatrician on 3 occasions. And all the 3 occasions, this pediatrician is sensitized to doing ESR, counts essentially normal, platelets are plus minus. But then what is very striking is when they come to me with 3 ESRs of 105. There is a significant weight loss of 5 kgs, and I just put my finger on the pulses, and there is a inequality in the pulse that I document. Take a 4-limb blood pressure and you find that the BP is discrepant, and then 3-digit TSR, unequal pulses, significant systemic features in the form of weight loss. This is a perfect scenario for an aorto arteritis. And this, what were the clues? This child actually went to the orthopedician with backache. An orthopedician said 13-year-old female with backache, ESR 105, let's rule out TB, and he advised a CT. And then the CT showed aortoarthritis. Then he comes to me and I set this child up for a CT angiogram, and then you can see that the whole aorta is narrowed. This is nothing but Takayasu aortoarteritis. What are the new things that we end up doing? Because many of these kids come in a burnt out phase, because the pre-pulseless phase. This girl has been going around for almost 1 to 1.5 years without anything other than an ESR of 105. And by the time she becomes pulseless, we have probably missed the boat. So here in the FDG PET comes handy, where the inflamed vessels can be picked up by the technetium dye. So this can be reversed with proper treatment also. So gone are the days where you may have been stuck with TB versus Takayasu. We have moved forward, and early use of biologicals have made a lot of difference. When from a large vessel disease, you may occasionally see PUOs in the OPD or in your IPD who gets admitted with high fevers. Again, sounds like a systemic arthritis, very high ESRs, joints, arthritis, hypertension, infarcts, and neuropathy. Remember this triad. When I have a hypertension of unexplained reason without any renal involvement or a proteinuric involvement, any gangrene, infarcts, when you start seeing fingers like this, with fever is almost a vasculitis. Without fever, think of an antiphospholipid antibody syndrome, wherein there is a vasculopathy. And then when you start seeing unusual, so this child actually has an infarct on the tips and then has the ulnar claw, so suggesting that this child has a neuropathy. And when you do an angio, it turns out to be polyarthritis nodosa. I don't expect to diagnose polyarthritis nodosa in a nursing home, but at least if you refer this child as a possible medium vessel disease versus APLA or an antiphospholipid story, that should be good enough. Clue is what? High fever, systemic symptoms, high ESRs, infarct, gangrene, neuropathy, hypertension, right? Medium vessel. This again, lots of kids in Raigad district every year. I keep seeing dozens of them. When you start seeing lot of explosive skin lesions, either discrete or isolated target like, these are called as medallion or medal like lesions. This was Dr. Chandorkar's patient, if I remember correctly, and very typically looks like henoch-schwann but doesn't have anything else like HSP. So you diagnose isolated cutaneous vasculitis. So the differential is just diagnose small vessel disease, rule out henoch-schwann, refer the child to rheumatology. Most of them will settle down on its own. So take home message from vasculitis is simple. When you start seeing a lot or hearing a lot of signs, but it's seldom that dangerous. So that's a small vessel disease. What is more dangerous is something which is very, very cutthroat. It's very to the point, ischemia, gangrene. That's a medium vessel disease. And the most sinister, which can be missed, is someone who is extremely silent for 1 to 2 years with absolutely no symptoms. This is a child where you need to put the finger on the pulse, hope that she doesn't come with severe cardiac failure, cardiomyopathy, etc. End up diagnosing Takayasu disease. I'll skip this child because I've shown you this child in the previous kid, but the kid the only reason I had this child here was this was a 7-year-old. So the pediatrician looked at a 7-year-old girl with ocular swelling, low-grade fevers, but a 7-year-old with severe constipation. That was one of the clues. And the child was referred to me. Something is funny, I can't explain. And I saw the hard palate ulcer, and when I checked for the joints, obviously these fingers were nicely puffed up, suggestive of dactylitis. And the CBC was very typically lupus-like, and a negative CRP and a high ESR is very, very suggestive of SLE. Still could not explain the constipation. And then, as it turned out, as a part of the lupus workup, the TSH I have never seen 100 in my life. So obviously, this child had autoimmune hypothyroidism, and all lupus markers fitted into the picture. And this child was started on L-troxin and lupus treatment, and the difference is that to be seen. Completely normal. This child is completely in remission now. So the clue is simple. Adolescent girl, any girl above 6'7", think of lupus, cytopenias, negative CRP, high ESR, right? Look at this 12-year-old. Again, the astute pediatrician referring a patient amongst 100 OPD patients only picked up 12-year-old girl with mood changes and decreasing scholastic performance, which was blamed on the typical adolescent story. Mother was sharp enough to notice handwriting changes, थोडं clumsy झालेली आहे, पेन वगैरह पडत राहतो, and there was significant weight loss. And the pediatrician said there is something funny, and this is what I saw in the OPD. And so again, my job is very easy. When I see a 12-year-old girl, I only think of tuberculosis and SLE. Obviously, this history did not fit in a TB-like story. But then this tongue showed the classical jack in the box phenomenon. And then I want you to see the other video. Just keep a watch on the fingers and the lower extremities. I'm trying to keep her engaged in a conversation while I notice that these are some funny involuntary movements that this child keeps on doing without so see this. So this is very, very typically, in addition to the jack in the box, what is called as a quasi-purposive or a semi-purposive movement. And sure enough, this girl had chorea. So the medical students, if they encounter this kind of a story to pass the exam, answer will be Sydenham's chorea. Whereas in practice, I think there are more lupus patients than rheumatic fever with Sydenham's chorea. And what did I do? The basic lupus workup. And remember, lymphopenia, thrombocytopenia, CRP negative, ESR 120. Sure enough, you are going to hit gold and diagnose SLE. So again, no butterfly rash, no mouth ulcers. This is an adolescent girl who's presented only with CNS features. So keep your eyes open. And when you look at a 12-year-old girl, please think of an SLE-like story. The last few cases are quite interesting because again, I thought is quite handy to the practicing pediatrician. Both of them were referred to me by the smart pediatrician only because ESR was 120. So that was part of the reason I am very happy. Now, the kid on the left was an 8-year-old girl with a recurrent rash on the lower extremity going on for 3 years. And it was blamed as Jari ka allergy, kapde ka allergy. And she had met dermatology who had asked for CBC and ESR. Again, very interesting that the dermatologist asks for an ESR. That time the white cells were 4,200 and the platelets were on the higher side. So what did we learn today? When you have a slight high platelets, please look at the hemoglobin. If it is not very low, think that it could be inflammatory. And a 3-digit ESR. As against the 10-year-old boy who came from Jalgaon. I remember this boy going to a teaching hospital with recurrent rashes on the lower extremity since age 4. The problem is the history which was taken was only 4 weeks. So they did a they did a biopsy of the skin rash because they thought it is enoxabolin purpura. And the biopsy came back showing leukocytoclastic or small vessel disease. And again, Reports are extremely similar to the kid on the left. 4,200, platelets 5.2, ESR in 3 digits. And the teaching hospital comes with its benefits. Serum proteins were done, which were high. Albumin globulin ratio was reversed. So there are clues. And obviously, the most important clue is going on for 3 years and going on since the age of 4, so 6 years. It doesn't fit into a straightforward HSP. And remember, enoxanin purpura is one of the condition where it barks a lot but seldom bites. You will never have a 3-digit ESR in HSP, right? So what did I notice in the kid on the left with the silk ka allergy had red eyes, and that was blamed on Ahmedabad ka dust, and it was labeled as vernal conjunctivitis or allergic conjunctivitis by the ophthalmologist. And the kid on the right had bad dental caries. Now these kind of caries in a 10-year-old boy, it should start making you wonder there is something wrong. You should, a 10-year-old should not get dental caries. So the take home message is, think of see a red eye with ESR of 120, start thinking as a rheumatologist would think of a dry eye. And when you see extreme dental caries, think that there is no saliva production, which means that this is a child who may have a dry mouth. And then you start adding dry eyes, dry mouth, high ESR, hypergamma long history going on. And then this is how the rashes look like. This is that Jarika allergy, looks like HSP, and this is the boy which looks like a classical HSP. But what was missed also was a history that this child since age 4 had recurrent parotid swellings. So again, a salivary gland issue with a dry mouth often points to what is called as a Sika syndrome, and a hypergamma often confirms the diagnosis of Sjogren syndrome. So remember, lupus is a diagnosis where you have low counts, low platelets. When you have low counts, platelets are on the inflammatory story, think that you could be looking at a primary Sjogren syndrome. So other than Takayasu, which can be extremely silently progressive, a Sjogren syndrome will give you enough of clues. So ANA positive, dsDNA positive, SLE. ANA positive, dsDNA negative, looks like a vasculitis. You are always thinking of lupus. Please send a rheumatoid factor. 80% of Sjogren syndrome have a positive rheumatoid factor also, possibly because of the hypergamma part of it, right? So again, take home message, dry eyes and dry mouth can manifest as red eyes and dental caries. You may not see Sjogren's in your life, but if you pick up even one in your lifetime, job is done, right? So what are the clues? Persistent low rashes, what used to be lower extremity rash, what is called as hypergamma purpura. This child is systemically well otherwise, a red eye called allergic eye, a severe dental caries, anemia, leukopenia, platelets slightly climbing up, a 3-digit ESR, please think rheumatology always. And if at all you end up doing a serum proteins, then a reversal of albumin globulin ratio, you are almost looking at a possible diagnosis of a Sjogren syndrome. Remember, Sjogren is the disease of a 55-year-old, not a 5-year-old. So the 55-year-old will have symptoms of Sika syndrome, dry eyes, dry mouth, etc. Whereas the 5-year-old can have any of these unusual manifestations, which makes pediatric rheumatology even more interesting, right? So take home message, HSP like rash with a 3-digit ESR, always think of lupus, Sjogren's, and in a sick child with proteinuria, think of ANCA associated vasculitis. If Dr. Atul Kulkarni is hearing this lecture, one thing I have learned from him is, other than patient from Solapur, HSP like rash with fever, I will add that the rash in the palms and soles, think of a rickettsial infection, which is very common in our belt. Occasionally, hello, hello.
Yeah, Vijay, you
Sir.
are quite
Yes, yes.
audible.
Please let me know if you are
No, no, you
tired.
are audible. No, no, not at
No
all.
problem.
Yeah.
No,
You
no,
can
it's
proceed.
very nicely. Please continue, sir.
You
Right.
can take your own time, sir.
Perfect. Thank you. Occasionally, these are kids who can just walk into your OPD. Unfortunate part is many of these kids walk into the dermatology OPD. And all I want all of you to see is the skin looks hyperpigmented, the skin looks a bit dark, a skin looks a bit tight, and start using proper medical terms: derma, tightness, hyperpigmentation, chronic inflamed skin, or what is called as scleroderma. The medical term for it is morphia. When you have multiple areas, you will call it a diffuse morphia. And this is a child where only a straight linear patch or a linear lesion, which starts from the ankle and goes up to the knee joint. And if you notice that this child actually came to me because she was not able to play tennis. And when you look at the two extremities, this has been going on for almost 1 year. You can see that there is a significant amount of wasting on the left side as compared on the right side as compared to the left. This is again a condition called as a linear scleroderma or a localized morphia. The problem is that this is a condition which needs immunomodulation with methotrexate for at least 1 to 2 years. And many of these kids will reverse back to normal if you pick it up early. If you don't pick them up early, you may end up with a situation like this boy on the left with severe contractures, vasculopathy, ulcerations, etc. So scleroderma, once in a while, you may pick up and then do the needful. So this was a child who actually was referred by again a smart pediatrician saying this is a 12-year-old female. So what does a 12-year-old female have? Lupus, probably Sjogren, or some connective tissue disorder. But the history was very interesting that there was weight loss which had started. This child's hemoglobin was always 7, 6, etc. This child actually had come to the pediatrician because the joints had started contractures or the joints had started contracting. Like the boy we saw in the previous slides, this child never had any stiffness. And just by age 10, 10 and a half, the joint started contracture. And when you start looking at this kind of the fingers, I want all of you to focus at the fingertips. These fingertips look very, very pointed or tapered, right? So I said, please send this child to me because there is something very funny about this history. And then the photograph that the pediatrician sent. So the way to get in touch with Vijay is Vijayचा phone lagat naseल तरीही 24 तास WhatsApp वर असतो. So the easiest thing to do is photographs काढा आणि WhatsApp पाठवा. Vijay will respond within half an hour because this pediatrician sent me this facial profile which showed a nice pointed nose. The fingers look pointed. The history was more systemic features. The fingers started contracting even without stiffness. And then I called this child for a consult the next day morning. And in my cabin, because it's a centralized AC cabin in Jupiter Hospital, this child's palms started becoming blue. The soles started becoming blue in front of my eyes. I had asked him to wait while I finished the rounds and come back. By the time I came back, this palms and soles started looking dusky. When you look at this kind of a spectrum, there is only one differential diagnosis. Now you know that the tight skin is called scleroderma, but because there were systemic features, there was a weight loss, there was a Raynaud's phenomenon, and then when you see Raynaud's phenomenon with contractures, you will call it a diffuse systemic scleroderma or juvenile diffuse systemic sclerosis. The previous slide was localized or restricted to the skin, whereas this is a condition where you have a systemic involvement. And the clue was Raynaud's phenomenon, contracture without having stiffness, and obviously tapering, which obviously means that there is a vasculopathy or a vasculitis that's going to set in very soon. How do I confirm it? I send an ANA, which by immunofluorescence comes back significantly positive. And once you have a positive ANA, you send an the ENA or the ANA blot, and this girl tested positive for SCL70, which is anti-scleroderma 70 positive, which is very, very specific for systemic sclerosis. What else does the pediatrician see in the OPD? So this is a very easy story to diagnose. Most of you will say, "Arey, is a classical muscle weakness hoga, heliotrope rash, Gauthron's papules." Remember, the Gauthron's papules along with the knuckles can also be seen on the knee joint, right? Any extensor surface, knee, elbow, etc. And then the take-home message that many of us may not be aware of is, do not restrict yourself only to CPK. You will add all the four enzymes: CPK, LDH, SGOT, and aldolase. Aldolase is not available in the UK, but we do it at our Metropolis and SRL. Remember, dermatomyositis can have any of these muscle group elevated. So it's always makes sense when you see a child with proximal muscle weakness and the classical dermatological signs, send all the four enzymes, which can be done even before referring to the rheumatologist. And then once we confirm that it looks like an inflammatory myositis, we may set the child up for an MRI of the thighs, which will start getting the treatment started. But what I want you to see is the straightforward. This was a child who was referred to me by the pediatrician saying, a classical JDM hai, but is not behaving like a JDM. Means this child was actually 6 years when she came and saw me and looked like a very typical JDM. The Gauthron's looked not very active but burnt out. But what was the reason for referral was this child actually had a lot of nodules, ulcers under the arms, and this was almost, all of us know that a dermatomyositis, when you delay the diagnosis or treat the child inadequately, you will end up with dystrophic calcifications, which is the worst thing that can happen to any child with JDM. And she actually came from Washim, and her X-rays were showing huge amounts of calcium in the subcutaneous layers, which obviously in the good old days you would have said 2 साल से चालू हुआ है 6 साल तक बैठे रहे इसलिए the child has become chronic dystrophic calcifications. But then and obviously it was not treated because the child was meeting a neurologist instead of a rheumatologist. The neurologist was treating this child as a polymyositis. But in the current day and age, when I start seeing this child, I saw this child in Pune, and this was how she was, with so much of ulcerations, and she had huge blocks of calcium around the knee joint that she was hardly able to get up, forget even trying to walk. So she was just reluctant. So what we do in this day and age is send something called myositis specific antibodies. So like you have the ANA blot, you have myositis specific antibodies and myositis related antibodies, which are specific to the certain types of phenotype. What do I mean by that? Why should this child have so much of calcifications, ulcerations, etc.? And so what happened is I asked for a myositis panel, and this child tested positive for, you don't need to go into much of details, but when you have this particular antibody, anti-MJ is the easier name to remember than NXP2. And anti-MJ, when it comes positive as a genotype, this child's phenotype is going to have all these complications which this child had. How am I wiser with that is, if this would not have been available, I would have probably gone methotrexate, high dose of steroids, then escalate to mycophenolate, etc., knowing fully that the calcifications may not be reversed. But because I have access to MSAs and MAAs these days, and I know that it's a bad disease genetically, I just upgrade my algorithm, and this child got rituximab and cyclophosphamide upfront, and you see the difference. She's put on height, she's becoming much better. And this would, I would have thought 1,000 times whether to spend money for rituximab, etc. And that's where the story would have ended. But the clever pediatrician said, it seems like an unusual JDM. And then he sent to me, I saw the contractures and the calcium deposits. Then we send this together. The pediatrician was very helpful, arranging for some funds, etc. And then this is the result. This child is doing reasonably well. I won't probably be able to reverse the calcified part of it, but definitely the disease has got arrested. So that's where the next generation pediatric rheumatology world is going towards. And what happens when you pick these kids early? A classical dermatomyositis sign, what is called as a raccoon sign, start picking them early, make them Cushingoid at 6 months, they look happier, start becoming better and better. And then one of the few conditions which can be completely cured in pediatric rheumatology is juvenile dermatomyositis. But it can be nasty if missed. So early pickup, early referrals makes a world of difference for these kids. One slide on ENAs. So we all keep using ANA Beju, DHDNA Beju, right? So remember, what is an ANA? It is an anti-nuclear antibody, which means I am producing antibodies to the nucleus of my cell. Now, which antigens in the cell is the ANA directed against? Is what is called as antibodies to extractable nuclear antigens. Means if I have an ANA that is directed to the Rho antigen in the nucleus, you pick up anti-Rho and you end up getting Sjogren. If you pick up the dsDNA antigen in your nucleus, you end up having SLE, so on and so forth. So remember, do not use ANA blot as a random story. You will use ANA blot only and only if ANA comes positive. And then always judge the patient's genotype, and then you send the extractable nuclear antigens. Then it becomes more relevant, because the test positive may not necessarily mean the disease, right? So we can discuss ENAs later on, but suffice to say today that ANA comes positive, you think of lupus, dsDNA comes positive, perfect. Think of dry mouth, dry eyes, caries, Rho comes positive, Sjogren, so on and so forth. So send antibodies to ENAs, which are also called as the ANA blot. So ANA blot to be done only when ANA comes positive. So the last part of the story is something that I see every single day, and the pediatrician must be seeing at least 10 patients every single day. This is a 5-year-old girl who walks in with severe पाय दुखतो. संध्याकाळ झाली तर पाय दुखतो. And the child is otherwise happy, normal, and the pain is more in the calves. And unlike the leukemic child, this child gets very happy with some iodex or jandu balm or hot water fomentation. And the next day the child is normal. And then when you examine this child is extremely hypermobile, loose ligament, lauchik, lachilapan, call it whatever, right? And then occasionally you may have a history of this is a girl who I had seen during my this is Dr. Koopchandani's patient, but I remember asking one child after seeing this in my OPD, W shape में बैठती है क्या? So the mom said कि बच्ची तो बैठती है, बच्चे का बाप भी बैठता है. W is in the genes, right? Times in your OPD, as the patients keep on getting more and more intelligent, growing pains आया तो calcium ही मिलने वाला है, तो they start troubling you with more issues, handwriting issues, speed issues, recurrent abdominal pains and headache is often the trimurti of hypermobility. Growing pains, abdominal pain and headaches is the holy trinity. Many of these kids will have mechanical aches and pains because of overstretching the ligaments. And many kids, I'm sure Dr. Abasaheb would have sent me almost 4 or 5 patients with pain amplification syndromes or fibromyalgias as we would have called it in the previous day and age, right? So this 5-year-old girl will come to you at 10 years with ज्या दिवशी खूप डान्स केलं त्या दिवशी पाय सुजतो आणि पाय हलवतच नाही. This is nothing but a benign joint effusion which many of these kids will have. Give them a rest for a day or two, this child will be normal. Don't end up investigating these children for any inflammatory process. When these adolescents become 16 years of age, they can have severe mechanical aches and pains by virtue of the low muscle tone, excessive ligament laxity, and the 10 kg school bag. That's a very classical clinical scenario where couch potato, bad posture, etc., etc. But when you examine this child, that's hardly anything wrong, except what the child needs is vitamin D and muscle strengthening. The other extreme, which is possible with so much of flexibility, ani lauchikpana, and if you think that this child is just about stiff, and this the kid in the middle will be happily smiling, ite dukto, tite dukto, vague aches and pains, whereas the last situation is someone where the child will have severe stiffness on extension of the spine, which is where when you see a hypermobile phenotype with a stiff back, ask for an X-ray. And the last time I think all of you would have seen such a picture would have been in an orthopedic textbook. The only thing that comes handy from the ortho textbook in my life is the Scottish Terrier or the Scotty dog appearance, where the facet joints keep rubbing against each other. So remember, the vertebral facet joints, by virtue of laxity, keeps rubbing against each other and ends up snapping at an adolescent age group. So this is a condition called spondylolysis or spondylolisthesis. Again, rare, but think that in a busy OPD, a adolescent girl comes with a low back pain who comes across as significantly hypermobile. You may be worthwhile more on extension, the pain more on extension, get an X-ray done, right? The other pathological conditions where extremes of hypermobility can be seen is Marfan syndrome. Obviously, we know the thumb sign, the wrist sign, high arch palate, etc. And this is a child I had seen during my training, and every single postgraduate exams, these twins used to come, and the question asked was, what is this deformity called as? And we would go nuts, what is wrong with these children? And you can see that the lower picture is the one leg is facing the front and the other is totally rotated, looking back, and severe hypermobility. Occasionally, once in a while in India also, I've seen one or two families where this is very consistent with the genetic collagenopathy or Ehlers-Danlos syndrome. We know that there are 8 or 9 variants, of which the type 3 is very, very specifically hypermobility variant, right? So remember to give a explanation to the parents for the aches and pains rather than bombarding them with calcium supplements and deworming agents, right? So hypermobility can be pathological, like you see here, or it can be physiological. So it can be asymptomatic, just comes with growing pains, and we've seen the pathological spectrum is the Ehlers-Danlos, the Marfan's, the Down syndrome, the Stickler syndrome, etc. The key is to pick hypermobility, counsel the parents that this is a condition where you may need to keep working up the muscles over time to prevent long-term mechanical issues. This I have covered. The hypermobility spectrum, which is the whole story in the pediatric OPD. The newborn child in the delivery room may be born with a developmental dysplasia of the hip. The child will have, many of these kids will have flat feet, growing pains around 5 to 8 years of age. Age 10 years to 15 years will be knee pain, ankle pains. And then age 18, 19 will be the spondylolysis listhesis. And if we do not address these situations, you may end up with degenerative osteoarthritis. So finally, what happened to this child? So this was the child who came all the way from a western suburb hospital, went from Andheri to, started from Andheri actually, and Dadar, and came to Navi Mumbai. And I saw this child in actually Gansoli. And this turns out that this child has received solumedrol, severe pain, query vasculitis, query malignancy, query JRA, query neuropathy, has received ganglion injections by the anesthetist for pain relief. Turns out that a detailed history taken, I just listened to the parents. This boy was extremely the Tare Zameen par phenotype, as I may call, was very bad in Hindi, was made to write the Hindi exam. There was a family bereavement. The grandmother had died. Father had lost a lot of money in the share market, and the parents keep on fighting at home. So a lot of psychosocial overtones, and the parents came and I keep taking a detailed history about all these issues because this boy was happily playing on the mobile phone outside my room, as sick as he likes, as he looks in this, so when there is a lot more symptoms and this child has an ESR of 10, is there something else that's wrong? And then this is where you end up diagnosing amplified musculoskeletal pain syndrome. Either it is diffuse, which is DAMPS or DAMPS, or it could be localized, one shoulder not moving, one leg not moving. So you can call it LAMPS and DAMPS. And the history is, if you are not in a real mood or you don't have the time, this parent actually, when I asked them, "Gari bandana hotat ka?" they said, "Bartan to sabke ghar mein bachte hain." That's the phrase they used to tell me. And I'm like, that's a nice catchy phrase. I should use it for the next time without offending the parents, because some parents do feel offended when their ghar mein jhagda hota hai kya. So I keep asking them, "Bartan bachta hai kya?" And they start laughing and said, "Haan, to bachta hai." So interesting, right? And what did I do? I stopped all the pregabalins and amitriptylins and just put him in a gym with under physiotherapy guidance. And this is the same boy who's become fitter, was from 85, he's become 70. He started exercising. We told him that Hindi ka exam de ke fayda nahi hai, etc., etc. And then he just start deconditioning these kids. And I'm pretty sure at least Dr. Abba has a factory of this in Mandgaon. He keeps sending me all these weird cases, but most of them have done well with the right kind of advice. So to conclude, what's the take-home messages? When it comes to arthritis, classify it into acute, subacute, chronic. Acute or subacute usually is associated with more of pain, less of swelling. So reactive, septic, osteomyelitis, etc. Acute monoarthritis, please rule out sepsis in a short history. A 4-week history with acute monoarthritis, rule out TB. Acute polyarthritis is seldom septic, often reactive, rarely a malignancy. When it comes to more than 4 to 6 weeks, more of swelling is obviously the rule because the process is in the synovium. A chronic monoarthritis or a monoarthralgia, please rule out TB and malignancy. A chronic polyarthritis is almost never septic. Occasionally, maybe malignancy, but invariably you will end up diagnosing a rheumatology story. When it comes to chronic, we are all experts now. 2-year-old, 2 joints, ESR2, and ANA positive is juvenile oligoarthritis. A 12-year-old female, 12 joints, ESR 100 is polyarticular JIA. An adolescent female can be RF negative JIA. And a 12-year-old boy with lower extremity joints, B27 or enthesitis related arthritis. When you have dactylitis or psoriasis, I didn't include that. You can think of occasional psoriatic arthritis. Remember, when you see a joint, it's always wiser to get an eyes check because when the eyes will give you a clue. And many times the uveitis in children is silent. The kid who I flashed the torch and I saw festooned pupil should not have had a festooned pupil. The eyes should have been checked the minute you saw the rash and fever and inflammatory markers, right? And the last slide, I think, is unexplained fevers without any focus, weight loss, headaches. They may end up presenting in emergency with CCF or cardiomyopathy. Put the finger on the pulse, 3-digit ESR, diagnose Takayasu. The single most message is dental caries in a big boy. Think of dry mouth, query Sjogren's, red eyes for no reason. Get eye doctor to do a filter test or a modified Shermer's test. Sure enough, they will come back saying that the child has dry eyes. May not be Sjogren, but it does help. Whenever you see anasarca, muscle weakness, rash like dermatomyositis, from today onwards, we will send all the 4 enzymes: CPK, LDH, SGOT, and aldolase. And last but not the least is a 11-year-old female with fever of unknown origin. Always, or anytime you use any autoimmune term, whether it is chronic ITP autoimmune hemolytic anemia, nephritis of unexplained onset, with the triad of anemia, lymphopenia, thrombocytopenia, a negative CRP, and a very high ESR with or without proteinuria, you will end up diagnosing lupus more often than not. Last but not the least, remember the non-inflammatory stories. I don't know at the end of it how many people are alive, how many conditions you will remember, but if I take a poll, it will take less than 30 seconds for all the audience people to name the movies in a clockwise direction, right? So Zanjeer, Dostana, Shahenshah 2, Agnipath, etc., etc. Why are we so much why is it easy for us to remember all the names? So for a start, when you see Vijay or when you see a joint, you remember Vijay is one message. When you see Vijay, by default, you will remember Amitabh Bachchan because we have been conditioned to that. And this has happened only by continuous reading, seeing, recognizing the patterns. And like the big man, he who has kept on revisiting and reinventing his life and keeping on repeating the same story. Life becomes very easy if you just spend that extra minute, try to understand or think why it happens. And most of the times you will probably end up at least remembering the rheumatologist, if not remembering rheumatology. Thank you very much. I'm pretty sure that's the last slide.
Great presentation, Vijay. It was absolutely like a rheumatology museum tour. Almost you have touched everything which we might have missed or we might have suspected. Great to listen to you all the time. In between, you check that whether the audience is there or not. But I tell you, if this would have been in a hall, it would have been like a pin drop silence. People were trying to, whatever you are speaking, just trying to put them to air. It is like that. So Vijay, you have absolutely done wonderful job and you have not kept any space for any question. Whatever questions I wanted to ask you, everything has been answered beautifully. And if at all, because you have shown so many cases, and if at all one has to remember everything, sometimes it may not be possible. But the things are there on YouTube video. People will visit, revisit, and try to see this video again and again because I think you have covered almost everything of rheumatology in this session. We are listening to you. We are since so many years, but this is I think one of the best so far. So there was one question in the chat box, but I think that also you have answered already. Just to sum up what a general pediatrician like us would have to remember from your talk is you have to stop looking and start seeing. You have to see the patient and just don't look at it. You have to learn to differentiate arthralgia versus arthritis because in rheumatology, arthritis which matters. While prescribing vitamin D for all bone pains or joint pains, just see that you have seen the previous prescriptions because most of the times vitamin D is bombarded on the patient. If you order some test, the tests are positive does not mean that patient has got a disease. So while ordering the test, you have to remember that for what reason you are ordering the test. If you are ordering ANA, situate that you are doing by immunofluorescent. Then if you are ordering ANA blood, you should have some sort of a clinical thought process behind that. Just don't do ENA or ANA blood because you have read or you have listened to the lecture. One thing is very important, if the child has got more pain, more shout, then one has to be very careful. Just prescribing anti-inflammatory or pain relief is not going to solve the purpose because there may be something which is like a leukemia or very serious disorder which is underlying there. So one has to be very careful when pain is more. If you are doing CRP, if you are doing CBCs, if you are doing ESR, don't forget that CRP and ESR together has got tremendous value in coming to some conclusion because the serial CRPs and ESR, you have taught us so many times, if they are going in reverse direction, ESR low, CRP high, CRP high, ESR high, how to come to conclusion, that is not going to be forgotten anytime in the life. You have got tremendous sense of humor, you have got tremendous sense of respect all the time you have said that whoever has referred to you, they're all smart pediatricians, they're all clever pediatricians. Many a times when we go to some specialty, subspecialty chapters, they always tell us that what you have missed, but you have rewarded us. Definitely, it's a great human being which is looked from your talk. Few things very important. It is very difficult to say that how much we have written from this, but very, I would say, at least we have learned what rheumatology is. Because to begin with, rheumatology is only joint. That is the only concept which people used to have. But rheumatology is not only joint; it is whole of a body. Everything from skin, every organ is involved in the rheumatology. So this is what insight you have given to us. Very wonderful presentation, Vijay. If anybody has to have any comment on it, you are most welcome. And thank you for sparing time for us.
Before, thank you, Dr. Abba, for summing it up so nicely. You were, while you were summing up the talk, I saw one question pop up, which also I have answered: how to contact Vijay Vishwanathan. So, if a pain
That's the
syndrome
reason I tell
from,
that it has already been answered.
if the answer given by someone who's extremely senior and respected is also wrong, because the patient with the bad pain syndrome swims his way to Jupiter Hospital, Thane. So there is no reason Vijay is not contactable or traceable, except that there are certain people who have timing issues, and Vijay works best when there is morning stiffness. वो बॉर्डर का जैकी श्रॉफ जैसा रात को 12 के बाद विजय becomes untraceable till sunrise. But I think the best way to reach me is send me a photograph. Send me the history, send me the chart. Life becomes so easy. You don't need me, you just need to pick my brains. And if I think that the patient wants me, I will come running to the patient, wherever it might be. And obviously my Kufia number in the busy pediatric OPD gets thought of as my WhatsApp number and goes to the patient. That's the only reason I don't give my Kufia number. But I guess I am more than happy to help anyone at whatever stage if needed. So the other questions I am happy to take if there are any. So
I think there are no questions in the chat box.
I
And we
have
have,
one comment.
okay.
Dr. Vijay, thank you very much. As you know, well, I was so tired and took a power nap and then I attended. And till last minute, I am attending this lecture. The beauty of this lecture is that you met few things we see that they are very simple, but they are complicated. And few things we think complicated, they are really simple. And yeah, and you analyzed all these things in very good fashion. I distinctly remember your first slide, test, test, nest. I thought this is something like Italy or French or something, and it was like distu tasu nastu. So it is so simple and so good. In between, you were using Hindi words and Marathi words. It's really beautiful. And thank you very much, Dr. Vijay. And especially Abasaheb Patankar, you narrated in very, very nice way. I respect a lot to you regarding your academic achievements and really good. And especially Dr. Vankade, thank you very much. You invited me. I know that you think that I am senior or something like that, probably, but in between the lines, you always think that Dr. Dabadkar, this is the time you should learn something and please attend. So thank you very much for encouraging me. Thank you. And it's very nice to see Dr. Mahesh Moite after a very long time. Welcome, Mahesh Moite. Your
Thank
comment,
you.
please.
Just two comments. One, I clearly know that Abba is totally recovered. Looking at his comments, he's
Thank you
back
so much. Thank you
to
so
work.
much.
We are very happy to see Abba back
Thank
in
you.
competition.
Thank you so much.
As Vijay, I think Vijay, I have heard your talk, the same talk, maybe with slight difference in the cases for at least 10 times. But I still feel that I have to learn a lot. Either I'm too dumb or you are too good at it. I don't know how to complete because it's something. What I was wondering is you could keep at least 45 out of 50 delegates stuck to this talk for more than 90 minutes. That's the beauty of this because rheumatology to us maybe 10 years, 20 years ago, I mean more than 2 joint refer, that's all. For some odd rash, you don't understand. कल आ जाओ परसों आ जाओ बाद में पेशेंट ही छोड़ के जाता है उसको किधर रेफर नहीं करना पड़ता है कोई निकल जाता है so I think you have made all people so wiser. I always keep wondering how do you remember all these conditions. I mean sure you are in that same field, you're seeing together, maybe decades together, but still, I always wondering you guys, you maybe few of the metabolic people or genetic people, how do you remember these various syndromes and all? I think you require a different kind of genetic structure to follow these kind of odd things. Again, kudos to you. Amazing talk as usual. And I always believe I have heard so many rheumatologists, but Vijay is one of the best
Vijay is
teacher
Vijay.
rheumatologist, I believe. He's one of the best teacher rheumatologists. At the end of the talk, you always get at least 4 or 5 practical things which can start implementing from tomorrow. And that's the best teacher. He don't shock you. He makes you feel that you also can do it. And I'm sure that's what all my colleagues in the periphery, Abba, Sunil, everybody is doing. So see the crowd. We had 55, 60 logins, many of them coming from out of Raigad. That's the one. I think in today's era, 50 delegates on the live web is not a small thing. Especially it's our district kind of a page, and where you have such kind of an attendance, it's credentials to Vijay's and his quality as a teacher. Thank you very much, Vijay. Wonderful talk.
Thank you, sir.
Thank you so much.
So over to Vikas.
I think Vikas is not there. Dhananjay, can you conclude, please?
Yes, sir. Yes. Thank
Yes.
you. It was a wonderful and extensive session on pediatric rheumatology by our very own Dr. Vijay Vishwanathan, sir. There is always so much to learn every time he talks on pediatric rheumatology. Thank you so much, sir, for taking your time and giving us knowledge to us. Thank you very much. Special thanks to Dr. Abasaheb Patankar, sir, back in action, and for wonderfully moderating the session as well as summarizing the pediatric rheumatology in a nutshell. Thank you, sir. Thank you very much, Dr. Dabhadkar, sir, Dr. Ganguly, sir, our Maha-IP President, Dr. Pramod Wankhede, sir, Raigad IP President, Dr. Mahesh Mohite, sir, Dr. Jitendra Gavane, sir, Navi Mumbai IP President, Dr. Vikas More, sir, and all the delegates who have attended this session. Thank you very much. And final thanks to Dr. Vishal Rao, sir, our digital man of IIP Raigad. Thank you very much.
Thank you.